Thank you very much. I'm going to try to talk to you not so much about telehealth as about how complicated health actually is. Okay? So I've been focused on the big data field. I'm starting a new venture fund of my own, but I have been a venture capitalist for about 12 years, and prior to that, I had done 5 successful startups. Okay? So frankly, I'm one of the inventors of the MRI scanner. I'm one of the inventors of the fingerprint sensor that's in the iPhone. And I'm one of the inventors of the 360-degree imaging that's now called Google Street View. Okay, so those are all 3 startups that I had done, and I had sold to Google, for example, on that last case. So I'm going to talk to you a little bit about the big data aspect of medicine here. Oh boy, I'm going to try to do this a little quicker. What makes us really different? That's the key issue. And I want you to look at Albert Einstein, who weighed about 150 pounds. And he weighed 97 pounds of oxygen, 27 pounds of carbon, hydrogen 14.25 pounds, nitrogen 4, and all the rest. Basically, now I want you to watch those numbers because I'm now going to show you a Great Dane, and the numbers are exactly the same. So it's not what we're made of that makes us different. It's how it's organized. It's how it's put together. That's what it is. It's how those atoms are put together, okay? What is attached to what, okay? How they pass around energy, things like that. How our bodies change each day. And I'm now going to talk to you a little bit about that. It's all information. That's what makes us different than dogs. Now, we have 100 trillion cells in our body, and they grow as we mature. Obviously, if you're a small person, you maybe have 90 or 80 trillion cells, and if you're a big person, you may have more. Each one of those cells has a genome in it, which has 3.1 billion base pairs in it. So we're talking about big numbers here, really big numbers. And then there's an epigenome on top of the genome, methylation patterns on the outside of the genome that turn genes up or down, on or off. I can tell you, for example, I carry a fatal disease in my genome, but it's methylated. It's turned off, okay? So I'm very fortunate in that sense. Then we have a microbiome, which is up to 1 quadrillion bacterial cells inside our body or on our skin or in our nostrils or in our lungs and things of that sort. And then we have 1 to 5 billion immune cells. And we have billions of viromes, and the communicome, millions, and the proteome. We are just big numbers. We're just very, very complicated. And what's interesting about it is the epigenome changes every couple of months. I'm not sure you know this, but in Finland they had a starvation event in the 1910s. In the 1930s they had obesity problems because their epigenome had basically made them make more fat, in effect, because they didn't have a lot of food. Well, the microbiome changes daily. If I go to a Thai restaurant tonight, my microbiome was different tomorrow. So it's changing all the time. And our immune cells are changing depending on what viruses or what bacteria we're being exposed to. And our virome changes almost daily because as I sit here and breathe, I'm probably breathing in viruses of one sort or another. And all these other things are changing. So that's one of the things that's amazing is that the numbers are huge and they don't even stand still. They are changing all the time. It's all code. It isn't zeros and ones. It's actually A's, T's, C's, and G's, for example, in the genome. So today, a doctor has less time per patient than they had 30 or 40 years ago. On the other hand, they have gigantic EMRs. I remember when I was a child, as a pediatrician, he would put a wooden stick in my mouth and look down my throat and take my temperature and make a diagnosis. I had a grandson that was born 4 years ago, and as he emerged from the womb, he had 2 gigabytes in his electronic medical record. So the doctor can't possibly understand all the data that he's got now. He's just sort of overwhelmed. In this case, my grandson had been basically genetically sequenced as a 9-week-old fetus by the company Natera, okay? So it was really kind of amazing that now the doctor just cannot deal with all the data they've got. And soon we're going to, basically everybody's genome's going to be in their electronic medical record, and that's going to be overwhelming. And then the methylation patterns on the outside are very important as well. What genes are turned on or turned off. I went down to Craig Venter's place. That's where I learned I had that fatal genome and things like that. I talked to Craig Venter when I came out, and he said that when he did the first genome, he found 2 fatal diseases in that guy's genome, and they were turned off because the guy was 76 years old and healthy. So that's one of the things that's changing a lot about the world, is it basically the genome and then the epigenome and then all these other things that are happening. It's just big data. Medicine has become big data. All these other things. And we're exposed to many chemicals in our food and toothpaste. If you think about it, George Washington did not brush his teeth. He did not use shampoo. He didn't do these things. If you just look at the outside of your toothbrush, your toothpaste, or the outside of your shampoo, or the outside of your mouthwash, or something like that, you're going to find chemicals in there that you didn't even know you were consuming. And I'm quite confident that in 20 years, AI is going to tell us there's correlations. If you're using Crest toothpaste, you have a higher incidence of oral cancer, or something like that. We're going to find a lot of very unusual things because there's so many chemicals in Wonder Bread and all these other things that we eat, okay? So it's really one of the things that's very interesting to me is that we don't even know all the exposures we're getting in some cases yet. So every patient is basically unique, and that's one of the biggest problems a doctor has. This is the personalized medicine world we're in now. Every patient is different. I invested in a company called Assurex that could tell what drugs worked for you genetically and what drugs did not. They told me that Tylenol did not work for me. And I knew that because I had taken Tylenol for headaches and it had not had any effect. They also told me I was 10 times more sensitive to opioids than anyone else. I remember breaking my leg skiing about 15 years ago, and I took hydrocodone and passed out, completely passed out. So I've learned that basically every patient is different, every drug is different, and every person needs a different dose. So it's personalized medicine. We're all slightly different. We all basically need custom drugs. I wouldn't be surprised in a couple of minutes that, in a couple of years, that basically we're not going to be given one drug for a problem. We're going to be given a multiple cocktail of drugs because they're going to need to basically deal with the side effects associated with the drugs that we have taken. Targeting is a big data problem. That's what my focus of my new fund is on targeting, making sure we know exactly what is the right treatment for that patient. And then vast data mining is coming to medicine. Doctors are going to need help from AI. They are absolutely going to need help from AI. So, doctors are today swamped with information. I have a doctor at the Palo Alto Medical Foundation who wears a Google Glass, and it actually tells her questions to ask me because it's looked at my electronic medical record and my history, and it already understands that I'm sensitive to certain things and not to other things. So this is what's happening. AI is going to help medicine. It's going to absolutely help medicine. It's coming. It's going to help the doctor see what's important, what questions to ask, and what the best courses of action are. And what's happening is we're already doing this with corn and grains and dairy. We're manipulating these genes and things like that, and we don't know what we're doing, actually, what the full concept of this is that we're doing. So we have been reading our genome for the last couple of decades, okay? And that's interesting. We're seeing defects and predispositions and things like that. We're identifying mutations. Cystic fibrosis is a single mutation. We're detecting pathogens and things of that sort. But what's interesting to me is we're seizing the steering wheel with CRISPR. We're going to be able to fix these things. A book I'm reading right now called Ending Aging by Aubrey de Grey, he's treating aging as a disease that can be cured. He's literally saying that in 50 years, you'll be able to live 1,000 years, which is kind of scary because I'm not sure this planet can handle 30 or 50 billion people, okay? I was actually on a panel with Elon Musk a couple of months ago, and I asked him, you got to terraform Mars fast. We need another planet. So we are right now able to write the genome. We're able to actually fix that. And we're also going to be eventually able to methylate the genome to turn things off that we don't want to have happen. So there's a whole lot of stuff that's happening, but CRISPR is the one that seems to be the most important at the present time. So it raises ethical issues. Are we going to eventually have designer babies? Are we going to actually eventually have babies that are 12 feet tall and are basketball players or something like that? This is something that we could potentially do in the next few years, and it's pretty scary, okay? We can also disrupt our ecosystems. You know, we can there's the law of unforeseen consequences is involved as we grab a hold of our own genome and start modifying it. So I'm going to just try to do this very quickly in terms of the things that are done. All these things that we're modifying right now and what those things are going to be. And soon we're going to be modifying our bodies continuously with wearables. I have an Apple Watch 4 right now, okay? And it looks at my EKG, and it tells Apple my EKG, okay, which is pretty amazing in itself. And this is what's happening. We're getting better and better at this. I think someday our EMR is going to become a live dashboard, and the doctor's going to call me to make an appointment as opposed to me calling him to make an appointment. Okay, so it's a pretty scary thing, what's happening. Anyway, that's it. So I'm happy to answer questions if you'd like.
Thanks, Nick. That was amazing.
Sure.
Any questions for Tim?
Excellent talk. This is the last sentence you asked. Pretend you have the Apple Watch 4. Actually, I'm planning to do this too. If we image project about 1 million people now, wear this Apple 4. And you will predict it will be every minute will be have a signal say, oh, my heart problem, oh, my blood. So
I've had AFib,
yeah,
so I actually know
where
that.
are you going to call the doctor, or doctor said, look, here, I know that, come over here. So I want to figure out this the problem. If you got 10 million, 1 billion people, where how do you do that data?
Well, this is the problem. Basically, when the internet was developed, everybody thought it was fantastic. Now there's fake news on the internet as well.
But that interrupt the people normal life.
I understand. We're going to need to limit some of these things. I don't want my life insurance company to look at my genome, for example, okay? I don't want that to happen, okay, because it's not good. They can maybe predict my age and figure out whether to charge me more or less. So we need limits on almost everything that we're doing right now, some control over it, okay? So.
Thank you.
Yeah. Yeah.
You talked about personalized medicine, but the way clinical medicine is conducted by all the academic institutions are phase 1, phase 2, phase 3. Our selection of patients has nothing to do with how unique every person is. And then you get this information and you try to apply it to everyone. Are you averaging here? So isn't it time to think twice about the way we do clinical studies?
I completely agree. I completely agree. I think one of the things that's most important in medicine right now is early detection. Because we find, for example, breast cancer often at stage 3 or stage 4 with a mammogram. I just invested in a company that can see breast cancer in saliva when it's only 4 cells, which means it can be treatable, okay? I wouldn't be surprised in 20 years if the doctor doesn't say, take this green pill. And he's not even going to tell me I have cancer. He's just going to kill it, okay? So that's one of the things I think we're happening is getting it early, finding it fast. I also just invested in a company that can do Alzheimer's disease. It can see Alzheimer's disease 8 to 10 years before dementia sets in, which I think is fundamental. Because right now we diagnose Alzheimer's disease when people start acting demented, and that means brain damage has already happened. Okay? So I think that's a fundamental one as well, okay? And I think that's what we're going to need to do. We need to basically make diagnosis earlier.
Are these FDA cleared or approved already?
The Alzheimer's disease one is not yet FDA approved. It's actually a Canadian company, but they are Canadian approved, okay, which I think is very important. The breast cancer one, they are just simply saying, if you do this, then go have a PET scan and you can see whether the beta amyloid's building up in the brain. So they are basically using it as a pre-check, okay, in effect. Yeah.
I think you answered this, but I was going to ask you the mechanism. Is the marker they're looking at the beta amyloid or the tau deposition?
They are looking at beta amyloid building up in the retina.
Well.
Yeah, and they can look in the eye with multispectral imagery.
Per human?
In a human. They've actually done the test on me, and I don't have Alzheimer's disease coming, so I'm very lucky, okay? They did the test on me, but the fact is they have done the test on other people, and 5 years later they did develop Alzheimer's disease. No, actually, they're in Montreal. Yeah, they're coming out of McGill University. Yeah. Yeah.
So, thank you very much. I mean, I'm very interested in this kind of a thing, a wholesome approach to removing barriers to healing. And thank you, Milton, for this one. I mean, I did not expect this kind of a lecture here today, and it is so amazing because I look at disease process as a complex process wherein we as providers and we as people who are involved in technology or medicine have to come together to do it. And understanding food as medicine and monitoring the microbiome changes and trying to make a difference, that has to
That's
be
a
the
huge
real
problem.
approach. And
I also think we're going to engineer viruses and bacteria to attack cancer,
yeah.
okay, for example. And so as a consequence, we may actually start treating diseases with engineered viruses and engineered bacteria.
See, I'm an infectious disease doctor and a wound care doctor and an obesity medicine doctor. People don't understand why I did all those three, but if you see, in people with sepsis, there is inflammation. Infection, there is inflammation, and obesity, there is inflammation. And what we eat causes inflammation. And adding all this to telemedicine and bringing that to people will then make them bring together and then add big
Understand.
data to it and
Right.
trying to understand this and trying to use nutrition. Say, what I've gotten into is understanding nutritional ketosis and diet that changed. I mean, in fact, I lost 40 pounds doing
I
that.
understand.
And that interests me in what you're doing. And are you doing anything with nutrition as a source of changes?
No, but
in-
I did something in specifically that area. Okay, I invested 6 years ago in a company that could see whether it was MRSA or just simple Staph aureus. What they did was they actually inserted into a bacteriophage a detection of the MEK-A gene that conveyed methicillin resistance into the MRSA, and if they found it, it set off luciferase. So they would take a nose swab and put it in a tube, and in 15 seconds it would start to glow if it was MRSA,
Yeah,
which is really important.
That is a technology that is being used now to rapid detection of PCR. And in fact, 8% of the patients who walk into the hospital and get admitted have MRSA.
I know it's a serious problem. I sold that company for $425 million to Roche. Okay, it was a really good outcome in that case. Yeah,
We need to talk.
yeah.
We
I
need to
invested at a $1 million pre-money valuation, and I got it. Yeah. Because I thought that was really important that they could do that. Yeah. Any other questions? Yeah, go.
Okay, slightly different tack is, do you see these advances in medicine increasing or decreasing inequality that already exists at a stark level globally and now even within the United States?
I think they are increasing. I think suddenly the doctor is suddenly being confronted with genomes and epigenomes and microbiomes and things like that. And I think that's one of the things that's very, very important. I was talking to my doctor a couple of months ago, and she said they had discovered some things in a microbiome that would turn off a drug that I was taking for something, okay? It could maybe stop an antibiotic from working and things like that. So this is the problem. We are a very complicated creatures, and there's so much chemistry going on in our bodies and things like that, and we don't even understand it all. We're just beginning to get the wind of it. You know, so.
A question back there.
Yeah.
So I'm just off of med school right now. I worked with CRISPR I had a trial with bacteria. I wrote my thesis on machine learning, so you would guess your talk was very important for me. But right now, I want to become a geneticist after this, but I don't see a clear path. I think that medicine as a branch has really lagged behind, and there's not that many training opportunities to get into these new emerging technologies. Even within genetics, they're still doing like dysmorphology and just seeing patients, and there's no real training available. What would you think is the best way to solve this in the next 5 to 10 years?
Well, that is one of the problems. I hang around Stanford and UCSF, who are two of the best institutions in the country, okay? They do really, really well, okay? And they will give you immunotherapy for cancer, for example. But if I go to Nebraska to a hospital, I'll get chemotherapy, okay, which is not necessarily good. It's just poisoning the whole body, just poisoning the cancer slightly more, okay? So I think that's one of the things that's a problem, is that we do not get medicine moved out. I personally believe that when you graduate from medical school, 5 years later, you should go back to medical school for 6 months and get an update, because medicine is changing so fast that doctors don't understand it. I changed my primary care physician because he went to medical school in 1991 and he didn't understand the genome at all, okay? But my new one graduated in 2008 and she did understand the genome, okay? So I think that's also important.
Gary?
Yeah, thank you, Ted. It's a wonderful talking. And,
Okay.
Yeah,
there you
yeah,
are.
Gary
Okay.
Chen, yeah. My question to you is, as a physician, as the patient, we also live in the society, and the treating patient who had a problem, like Alzheimer's disease, as you say, is too late. But the most important is how to prevent it happen and treat it earlier. So
I
now,
understand.
the hot topic right now, besides of the Alzheimer's disease, but lots of people, and beside of the cardiovascular problem, but also the cancer is still the target for everybody's scared, because when people get diagnosed with cancer, almost
It's
no matter
terrible.
what you say, it's going to be
Sure.
someday will be soon to die. So now, what's your opinion about current the trend about those are the gene the diagnosis testing to prediction of the future the risk of a cancer in your body. For example, we started to classify based on the different tumor, like from your lung cancer,
Yeah.
breast cancer, prostate cancer, kidney cancer, those common
understand.
issues.
Yeah.
So what's your comment on this?
Well, one of the things that's very important that I don't think many of the people in this room understand, we carry caveman genomes. Genomes don't change very fast. Cavemen lived 30 or 40 years. That was it, because their kids could run faster than them away from a saber-toothed tiger. Okay? So it's the fact is, we carry caveman genomes. And the fact is, cavemen did not eat much sugar. And I can tell you, I just read a scientific paper. They said they did autopsies on a whole bunch of people who had Alzheimer's disease, and they found sugar in their brains. Okay? So I'm thinking that a lot of what we're basically facing in the way of healthcare challenges are things we're just eating ourselves. Okay? That, getting, Frosted Flakes cereal or something like that. And that's one of the biggest problems we face, is we're not eating like cavemen, yet we have caveman genomes. And we're living twice as long as cavemen did, and things like that. So I think that's one of the biggest problems, is we need to start thinking about that. Eating more roots, eating more vegetables, and things of that sort,
Brian?
Yeah.
So thank you very much. It's refreshing to hear your perspectives. It's also refreshing to meet folks or hear from folks who are actually trying to catalyze really significant forward-looking change to a group of people who think a little bit differently as well. My question to you is, how do you foresee our ability to actually catalyze this kind of uptake of ideas in the developing world? So some of us are working
It's a big challenge.
I mean, really, we're helping build health systems now, but we're using the mentalities of 50 years ago to do it. And those of us who are relatively junior, even though we see what's coming, are not in the positionality to help evolve that very well.
Telehealth may be actually an important part, because it may be that somebody in India needs to talk to somebody in California to get the best care, or something of that sort. So telehealth may be very, very important in that area, but this is a big challenge. Right now, the care you get in Nebraska is different than the care you get in California. The care you get in Uganda is different than the care you get in Nebraska. Okay, so this is one of the challenges, is it's just scattered all throughout the world very differently.
I would also like, real quick, just make the suggestion that if we're going to be talking about telehealth or telemedicine for the end point of actually providing care, we should also be talking about using it for teaching and so
I
people
agree.
are comfortable all the way through. And it's not something I've heard much about, but I feel like Like, that's one area I want to be working on
I
as well.
agree. And I can tell you, I'm not sure you saw it, but the European Union has now basically said that the medical journals cannot charge $1,000 for papers anymore or anything like that, because they're saying we got to get this information out. It takes 9 months after you've basically written a paper that shows something important before it gets out. And so I think that's important. I'm an investor in a company called Curious that's up in San Francisco that can publish things in 3 days. Yeah, online. And that's really important. So,
question, then the last one.
yeah.
I have a two-pronged question. You brought up the concept of bioethics. There's a whole bunch of, and it always lags
There are a
behind
lot
the
of big
tech.
problems there, yeah.
Who is going to regulate, designer babies? Is it the FDA, the payers, CMS, or who do you, Congress?
I honestly don't know the answer to that question because I'm
Okay.
not a politician, but,
Who do you think is, okay,
but it's a tough problem. That is a tough problem because I think that someday, Wilt Chamberlain's going to have a child that's 10 feet tall, or something like that.
And the other important question is cost and accessibility. Again, as a patient advocate, I mean, I know some of these genetic tests are $4,000, $2,000. Our insurance is going to pay for it. My colleague Kyle, who's an entrepreneur,
It's getting
young
much
guy.
cheaper now. It's getting much cheaper. I paid much less than that to get my genome sequenced just recently. So I paid like $300 to get it done, and I wouldn't be surprised if it can't be done very soon for less than $100. So I think that's happening. Yeah.
With all the tests and all the data that's being generated, you mentioned the fact that you also don't want your insurance company to know about that data. So as a futurist,
My life insurance company. Okay.
and as an investor, what opportunities do you see around protecting this data and systems for storing the data and sovereign identity and things like that?
We live in a world where there is very little privacy right now. AT&T knows where I am at all times because they know where my phone is, okay? And that's part of the problem, is there is not a lot of privacy. But I think in the healthcare space, in the life insurance space, I think that is important, okay? And I think we're going to have to pass a lot of laws as we move into this big data world. We're going to have to pass a lot of very unusual laws that prevent certain people from looking at certain data and raising your prices because of it, or something like that.
Do you think individuals will start to maintain their own data using?
I would not be surprised, and I can tell you my iPhone contains my medical record right now and things like that, and I wouldn't be surprised someday if I don't bring my medical record in to the doctor as opposed to they're looking at it on the computer, and it stays in my phone. On the other hand, I wouldn't be surprised if AT&T can't look at it, so that's the other problem.
Thank you so much
Yeah.
for the awesome. I guess.
My pleasure. Yeah.